starting on airway management. Let me get my chat pulled up so I can see you guys. All right, so chapter 10, airway management. Airway management is really important. Okay, secondary to learning how to do patient assessment, understanding that what an airway is, and how to handle an airway, how to procure one, provide one, however you want to say it, is super important, because without the airway, there's no breathing. And if there's no breathing, then there's really no circulation. So airway is the very first thing that we have to worry about. And, you guys can read these slides as I just kind of click through them and tell you. But first things we're going to go over is our anatomy, and then our assessment, and then all of the different techniques. But we want you to understand what a respiration actually is. We're going to go through that. We're going to show you the definitions, but also what you as an EMT, as a provider, can do to help with these things. And we're going to go through what artificial ventilation is. And these are things that we provide our patients as we continue on. And of course, we'll go through patho. So let's just go through the introduction real quick. The primary component of caring for patients is ensuring that they can breathe adequately. That's the primary thing, right? Super easy. Just make sure you can get air in and out, right? And in all honesty, that's really all the airway is. It's just a tube that allows air from the atmosphere to go into the lungs, fill them, and the lungs take away the oxygen, and the body gives out the carbon dioxide, and that air just comes right back out that tube. It's essentially what an airway is, okay? And of course, I'll just read this. When the ability to breathe is disrupted, oxygen delivery to tissues and cells is compromised. So what are some of the signs and symptoms that we already know about when that happens? And anxious patience is the first sign. Later signs are going to be cyanosis, bluing of the skin. People have an altered mentation, because remember, we discussed very early on that our brain needs two things to survive. The very first one, of course, is glucose. The second one, which I'm not sure if it's more important or not, but it's oxygen. Okay, so if we don't have an airway, we can't have oxygen, and our brain will shut down. So the very first thing that happens is we have that altered mentation, that anxiousness. Okay. But oxygen reaches body tissues and cells through breathing and circulation. And here is a beautiful anatomy and respiratory, or anatomy of the respiratory system. And you have your upper airway, and then you have your lower airway. And we are going to go into this in just a few minutes. So make sure that you guys see figure 11-1, and you guys can go back and look at that, whereas I have to continue on. So the respiratory system consists of all the structures that make up the airway and help us breathe or ventilate. So the definition of ventilate is just air moving in and out. Okay, the airway is divided into upper and lower airways. So let's talk about the upper airway. Now, you have your nose, mouth. Nose, mouth, oral cavity, pharynx, and larynx. Okay, these are all structures that are going to be above the vocal cords. That's what your definition of an upper airway is. Its main function is to warm, filter, and humidify air as it enters the body. So let's go back. We're going to go back one more real quick, because I want to tell you guys what this is all about. Our nose, inside of your nose, you have these little hairs, okay? And those hairs and turbinates that are inside of your nose, what they do, the hairs filter out all of the smoke and different particles. So that stops that from going down into your lungs, right? Awesome. The turbinates in the back of the nose, in the back of the nares, that's going to warm everything. I don't know how to stop this from going off, so hold on just a second. I think if I say something in the chat, I won't be hearing that, and it's really bugging me. Okay, I'm just going to put okay in the chat. Y'all just ignore me. I'm just hoping that the ding will go away. In the mouth, if you've ever walked outside in the morning and it's like really, really cold, and you breathe through your mouth, your lungs will feel that cold air hitting. And so that's why you want to breathe through your nose mostly, because those turbinates will heat up the air. And then the oral cavity, pharynx, and larynx. So the pharynx is going to be that muscular tube that is extending from the nose to the mouth. it's right about back here, to the level of the esophagus and trachea, and it's composed from top to bottom of the nasopharynx, oropharynx, and the laryngopharynx. So it's a whole bunch of different words, but naso, meaning nasal pharynx, okay, nose, oro, meaning oral or mouth, oropharynx, and then your laryngopharynx. So those are, if you break these words down, guys, these are super, super simple to understand. Okay, the nasopharynx also filters out our dust and small particles. It warms and humidifies air as it enters the body. However, it's not all, we start up here at the nose, the nasopharynx. I just wanted you to know that. And so when we're breathing in, let's say, I'm sure I've got a lot of firemen here, or if you're not a fireman, you understand what happens in a fire, right? Everybody's probably been around a bonfire. So when you're breathing in all that smoke, it's not just the smoke, but it's also the particulates that come with it. Dust, all sorts of nasty that's out in the atmosphere. And so that's the very first part that gets taken out. It gets filtered. And then as those smaller particles get smaller and smaller, later on, there's another filter for that. But what another thing is it warms and it humidifies the air through those turbinates that are located in the back. All right, the oropharynx is the posterior portion of that oral cavity. So it's not like inside the mouth right here. It's kind of towards that back area. And then the epiglottis, that's that hangy ball thing. Okay, not gonna lie, that's what I grew up calling it, the hangy ball thing in the back of the throat. Well, actually the hangy ball thing back there is called, now I've gone blank because I made something stupid up. But anyway, that's going to help also with filtering. And in a minute, I promise I'm going to remember that name. But if you know it, can you help me out? Throw it in the chat. And then the uvula, thanks. I feel like a dinghy. That's also going to help with filtering and everything else. Now you have your epiglottis, and that is superior to the larynx, and this is going to help prevent food and liquid from entering the larynx during swallowing. So what happens is this flap goes over it, and it says, no, you can't go in here. Only food is going to go in this one. So it's just going to hold this over, and then you have air in the other one. I got you. Don't worry. Thanks, Lindsay. I'm glad I can make everybody probably laugh at home. I'm sure you guys got a good one. Oh, I could have gone to the very next slide. Wow. Okay. So this is going to show the oral cavity, and I don't know if you guys can actually see my pointer, but I do want you guys to look at the tongue on this side and see how large that is. And I know I'm going a little bit ahead on this, but I want you guys to understand that one of the differences in the airways of our children versus adults is that the tongue is much larger in a child's mouth than it is an adult, because to be honest with you, the tongue doesn't really get much larger from when you were a kid to an adult, and their jaws are much smaller. So imagine this tongue being in a child's body, essentially. Okay. Okay. All right. Sorry about that, you guys. All right. Moving along. Check this out. Make sure you understand what you're looking at here. Look over here to this side where you see where the oropharynx starts. And then the nasopharynx, oropharynx. There's your epiglottis. Remember, that's that tiny flap. So you want to make sure that you know where these markers are in the body itself. And this is the larynx, and they call this a complex structure formed by independent cartilaginous structures. And yes, it is. You see that nice little spot right there called cricoid cartilage? That's where there is a potential for an airway. We're not going to go over that, but you've probably heard of somebody having a cricothyrotomy. That is the tiny little piece that you go into and cut. And so you can see that there's a lot of different areas around that area that can be damaged. So it marks where the upper airway ends, and then this lower airway is going to begin below this area. And if you want to know where it is, literally find your Adam's apple. It does not matter if you're a female or a male. I am very much a female. I have an Adam's apple. It's just not as prominent on me as it is on males. So if you want to find it, there it is. Your thyroid cartilage is going to form a V shape interiorly. Remember, we talked about where our landmarks are. So anterior means towards the front. The cricoid cartilage is the first ring on the trachea, and you can feel it. You can palpate on yourself. I do not suggest pushing too far on the inside because you will hurt yourself. And then your glottis is the area between the vocal cords, that glottic opening. And this is the narrowest part of an adult's airway. And remember, when you're looking at a vocal cord, if you're looking inside of a mouth, what that looks like are going to be two bands, white bands of thin muscular tissue. And when they're breathing, it will open and close like this. And they're just partially separated at rest. So, but what this does is obviously the vocal cords produce your speech, and it protects the trachea from the entry of substances like water and even vomitus. Now, the lower airway function is to deliver oxygen to the alveoli. Okay, how interesting is that? We're still talking about a tube. It is to deliver oxygen to the alveoli. And so the lower airway is going to include your trachea, your bronchi, and your lungs. And the biggest way that I always remember, I love saying keep it simply sweet, because KISS is more positive than the other version. So the way that I recall, like, well, is it trachea or is it the other one? Well, I know it's an endotracheal tube. So if you ever get on an A&P test and you're wondering which one goes to the lungs, it's an endotracheal tube. I hope that helps someone. So the trachea is the conduit for air entry into the lungs. Once again, there it is again. It's a tube. That's all it is. It's divided into the at the carina, which is going to be, it's going to come straight down. And then at the carina, you have, this is the carina where it makes kind of a V. And this is when it changes into the two main stem bronchi of the right and the left lung. And then the bronchi are supported by cartilage, and the bronchi distribute the oxygen to the lungs itself, okay? So as it comes down, and we're going to see that in the next slide, but as the air comes down the trachea into the main portion of the trachea, it's going to go to the right and the left through the main stem bronchi, and the bronchi are going to also branch out. That's why there are a lot of artists out there that say that the lungs are the tree of life. And a lot of, if you can look that up online, there's some beautiful artwork that show that the alveoli are actually leaves on the tree. It's very beautiful. But as you can see here, you have your main two, and then the other smaller ones are called bronchioles, and then it gets smaller and smaller until we have the alveoli that are all set at the very end. And the bronchioles are made of smooth muscle, and so they are going to open and close, and that's very important for you to understand now ahead of time, especially you guys in advanced EMT. If you guys are listening to this lecture, you need to remember that smooth muscle in the bronchioles opens and closes as a muscle would. And why is this important? Because later on we talk about pharmacology. We're going to talk about some of the drugs that are going to interact with those smooth muscles. So smaller bronchioles connect to alveoli, and the oxygen is transported back to the heart and distributed to the rest of the body. And it has to go through the heart to continue for it to go through the body, right? But let's talk about what alveoli actually are. There's millions of these thin-walled little balloon-like sacs, and they're all over the place, and it's almost like little bitty grapes at the end of these, and they're pretty cool to look at, by the way. And so what happens in these alveoli, when the oxygen comes into this sac, it's going to diffuse. The oxygen diffuses over the membrane into the capillaries that are going to run right below it. And I'm sure that I know it's coming up, but the capillary beds are right here at the end of or surrounding each one of the alveoli. So the oxygen will diffuse over into said area. And when it does, it diffuses oxygen over here, and then carbon dioxide replaces it. So when the body is exhaling, when the lungs are allowing the air to be released and go back out in the atmosphere, now it's full of carbon dioxide. I hope that made sense. Okay, so the heart and great vessels, or the vena cava and the aorta, are also present in the thoracic cavity and are very important for respiration. And you will note very quickly, I want you guys to look at this and tell me what's the difference. What's the difference in the left lung from the right lung? Go ahead and put that in the chat if you can tell me real quick. Anything very obvious. And by the way, advanced EMTs that are here, I'm one of those instructors that I am just going to sit here and wait for someone to answer me until I move on. 3 versus 2, 1 is bigger. Needs room for the heart. And you guys, you actually all got it right. And lobes, exactly. So if you look at one side of the heart, there are 3 lobes. However, on the other side of the heart, there are only, or on the other side, there are only 2 lobes making room for that heart to sit directly inside of it. So even though this isn't extraordinarily important for you to know right now, it kind of is. These are things that are all made sense. They all fit perfectly. And so you need to understand that this little cavity right here is very important, okay? Okay, so let's talk about the mediastinum. And this is just this area that we're talking about, okay? And that's the area between the lungs, and it contains all of these, that heart, great vessels, esophagus, trachea, your major bronchi, that's gonna be your 2 main stem, right? And then a whole bunch of nerves. Okay. So the respiratory and cardiovascular system do work together. They do work in concert together, as you will see in the next few slides, how we're going to talk about, and when we get to the cardiovascular system, you're really going to see how it loops through to the lungs and everything else. But it ensures a constant supply of oxygen and nutrients delivered to cells, and it removes carbon dioxide and waste products as it goes. So first and foremost, let's go right back to what we said earlier. And I've gotten ahead of myself, but I'm glad I did. We have this constant supply. So air comes in, it goes all the way to the alveoli. The alveoli push it off against the capillary bed. Oxygen goes into the system. The capillary bed takes it to the heart. Okay, and the heart takes all of that oxygen and pushes it out to the rest of the body. Right? Now, the flip side of that, the alveoli is now smaller, but we still have carbon dioxide and waste products that we need to get rid of that are coming in this way. So now my alveoli will fill up, and when we are expressing, we are getting rid of, we are breathing out waste, okay? We're breathing out carbon dioxide. So let's talk about what the function versus definition are. And table 11-1 is something very important for you to understand. Go ahead and get it down now so that as you progress, this is just easier for you to understand. Ventilation is the physical act of moving air in and out of the lungs. That's it. We're ventilating. So if someone is not breathing well enough, or they're not breathing at all, and I take a bag valve mask and a BVM, and I have a really good seal, and I depress my bag, I'm ventilating. It is literally the physical act of only moving air into and out of the lungs. That's it. Oxygenation, on the other hand, is the process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. So what does that mean? You can ventilate without oxygenation. You can ventilate, I can ventilate all day and have maybe a blockage somewhere, and it's not getting past that area. That's not going to cause oxygenation. So oxygenation is the process of loading oxygen molecules onto the hemoglobin molecules in the bloodstream by, remember we talked about alveoli, get a lot of oxygen. Here's the capillary bed, and it diffuses over. Here we go. This is part of oxygenation. Respiration is the actual exchange of oxygen and carbon dioxide in the alveoli as well as the tissues of the body. So, you know how when we're coming back, our bloodstream is coming back to our lungs, to our alveoli, and it's saying, hey, you can have this carbon dioxide. That carbon dioxide had to come from somewhere. So at your tissues, as this oxygen is being delivered to the tissues are saying, hey, you can have this carbon dioxide. I'm done with it. Thanks. Have a nice day. And it transports back to this capillary bed around the alveoli, and we get rid of it there. Okay. So physical act of moving air into and out of the lungs is ventilation. So inhalation is going to be the active muscular part of breathing. The diaphragm and intercostal muscles are going to contract at this point, and this generates a negative pressure in the thorax, allowing air to enter in. So I want you, everybody, to stop what you're doing. I want you to take a deep breath. I mean, a deep breath. I want your stomach to move. I want you to feel the intercostal muscles contracting and pulling the diaphragm down and creating that negative space so that your lungs can fill. Go ahead and do it. Go. And now release. Okay. Do you feel that active? There was an active motion there. So that's what that is. That is a physical portion of moving air into and out of the lungs. All right, so the lungs require the movement of the chest and supporting structures to expand. Your supporting structures, of course, are going to be your diaphragm. Partial pressure, this is the amount of gas in the air or dissolved in fluid / we're talking about blood, okay? So we're going to change our partial pressures here. Oxygen and carbon dioxide both diffuse until the partial pressures in the air and the blood are now equal. And that's going to be about 104 millimeters of mercury. I don't really know if you need to know that, but there it is. And the partial pressure of carbon dioxide in the alveoli is going to be 40. So what happens is deoxygenated arterial blood from the heart has a partial pressure of oxygen that is lower than the partial pressure of carbon dioxide in the pulmonary capillaries. And I'm reading this directly from the notes. This is in your books, guys, okay? The body attempts to equalize this partial pressure. Absolutely. And this is where we have that oxygen diffusion. And then oxygen and carbon dioxide will both diffuse until the partial pressure in the air and blood are equal. And so that's why we have this diffusion process. Okay. And here you see in figure 11-9 what it looks like to have your lungs. It looks like a bell jar, literally. You guys can look at that in your books. Okay, so inspiration delivers oxygen to the alveoli. There's your, but not, I want you to know, not all inspired air reaches the alveoli for gas exchange. So remember we said we had a tube, that our airway is just a tube. Well, there's a lot of negative space there. And that negative space, there's no respirations taking place inside of that negative space, okay? And by respiration, I mean like there's no gas exchange taking place. So keep that in mind so when you take a really, really deep breath and you inhale as much as you possibly can, not everything that you're inhaling is getting into your lungs, okay? Tidal volume, that's the measure of one depth of breathing. That's about 500 mLs for an adult. And the definition of dead space is the portion of inspired air that fails to reach the alveoli. And it's because of all this negative space, okay? Now, exhalation, okay? Exact opposite, right? Does not normally require muscular effort. Remember, I told you guys 2 days ago in lecture, there's a lot of stuff that we have that's all or nothing, but then there's always but not normally. Normally it's okay, or normally it's this way. Well, here we go. You're going to find out about the not normally later on, so let's just find out about normally. But put that in your cap, okay? So this is a passive process. So to inhale, remember, I had to actively inhale. I had to actively make my muscles move, right? But exhalation is just passive. I can just let it go. It's like a balloon. You just open the balloon up, it just goes away, right? The diaphragm and intercostal muscles, they're going to relax, and the smaller thorax compresses air into the lungs. And that goes into the smaller spaces. The air pressure in the thorax is then higher than the outside pressure, and air is just pushed out through the trachea at that point. Now, there's regulation of ventilation, involves a complex series of receptors and feedback loops, and there's a lot that goes on there. There's the gas concentration in the bodily fluids, and it sends messages to your respiratory center in your brain, and it adjusts your rate and depth of your ventilation as it goes. So the body has this need for constant oxygen. And trust me, if you try, hey, let's hold our breath for as long as possible. Who wants to have a contest? This is just a thing. I'm not actually saying this is what you're going to do. Hold on 2 seconds. Okay. Just got a message. Chris is on his way, guys. Where was I? Okay, body needs constant oxygen, right? So if you do the hold your breath contest, once you get through, you're like, because your body's trying to catch up from all that oxygen that you didn't have. So failure to meet this need may result in hypoxia, which is a condition in which the tissues and cells of the body don't get enough oxygen, right? And I'm going to tell you one thing, you can't hold your breath long enough for you to pass out. That's not going to happen. Your body's just going to overcorrect. That's why people drown, because they know better than to take that breath of water, but our brain overrides it and says, hey, I need oxygen. I don't care where you're at. So if not corrected, your patient may die quickly. Hypoxic drive, though, let's talk about this one. Let me go back over here to these. Based on the pH changes in blood and cerebral spinal fluid. And we talked earlier about a series of receptors. You have some receptors inside of your heart, and you have some receptors inside of your neck that are going to help with deciding how much oxygen and pH you have in your body. And it's going to say, hey, I don't need that much, or hey, I need a lot more. Thank you. And it's going to send all those messages to your brain. Okay, so hypoxic drive is different. And that's where the primary control of breathing is that it uses the levels of oxygen to control breathing. So typically, this is going to be seen in your end-stage COPD patients, not necessarily beginning stages. So some believe that administering high levels of oxygen will increase the amount of oxygen dissolved in the plasma and negatively affect the body's drive to breathe. What does that mean? That means that there are people out there that surmise, and we're not going to test this. And y'all understand why. Why would we test something like this? Oh, I'm going to just give you too much oxygen to see if you die. That's not okay. But they surmise that because this is based off of the oxygen levels, the body's like, oh, well, I've got 100% O2 now. I'm just going to stop breathing. I don't need to breathe as hard. But their normal is like 88%. And so that's bad. So that's where we're at with the hypoxic drive. We're going to learn more about hypoxia or hypoxic drive and COPD later on in some future chapters. Let's talk about oxygenation next. The process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. That one's pretty easy, right? That sounds pretty awesome. Required for internal respiration to take place. Well, wait a minute, Miss Patricia, isn't it all internal? Yes, it is. I know that is so confusing. When I went through EMT school, I just really wanted to ask my teacher, like, what do you mean internal respiration? It's all internal. But what we're talking about is, hold on. Okay, you're fine, Connor. Just pick up where you can. So it does not guarantee that internal respiration is taking place. Oxygenation does not guarantee that. Ventilation without oxygenation can occur. Remember we talked about a blockage? Remember we talked about blockage? Okay. COPD can have a blockage. CHF can have a blockage. Heck, you can not chew a piece of steak enough and have a blockage, okay? In places where oxygen levels in the breathing air have been depleted, such as in sometimes mines, confined spaces, high altitudes, when you go up, they have what's called blood doping. In sports such as track and decathlons or triathlons, biking mostly. So you'll see that in like the Tour de France. But they go up into these high altitudes and they'll work out. And then they'll go and they'll give blood. And then they'll wait when they need that blood later on. That blood is super high in oxygen because at higher altitudes, you have to have more oxygen to do the same thing that you would at lower altitudes. Anyway, but that's against regulations. That's actually really bad. Okay, so respiration, the actual exchange of of oxygen and carbon dioxide in the alveoli and in tissues of the body. Cells take energy from nutrients, such as a series of chemical processes known as metabolism. And that's going to be our cellular respiration. And so each cell contains nutrients and oxygen producing energy and waste products, mainly water and carbon dioxide. And there's going to be a change in all of those. That's going to, your cells are going to take energy and they're going to give all the nasty away, all the waste products away. All right. And here you see the external respiration or the pulmonary respiration. And this is the process of breathing fresh air into the respiratory system. And then there's the exchange of the oxygen and carbon dioxide between alveoli and the blood in the pulmonary capillaries. Now, have you heard the word surfactant before? I'm sure you have somewhere. And what that is just a little bit of, is someone unmuted? Someone have a question? Okay, maybe it's my computer making noises. Okay, surfactant is like just a little bit of fluid. It's kind of viscousy, and it reduces surface tension within these alveoli, and it also keeps them expanded. So if you don't have enough surfactant, your alveoli are going to collapse. That's why it's so important when we have these babies. Especially very early on, they have to get medication to get that surfactant up. But this makes it easier for gas exchange to occur. And I just wanted to make sure that you guys knew about that as we moved along. Now, here we go. Internal respiration. This is the exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells of the body. So as you can see here on figure 11-12, you have that internal respiration, and you see everything moving. Okay, the oxygen is going to pass from the blood into in the capillaries to the tissue cells, and then carbon dioxide is going to pass from the cells into the capillaries. Then that blood is going to be transported through the venous system back into the lungs, and that's going to be exhaled out. And so cells not only need a constant supply of oxygen to survive, they also need the cells to be able to get rid of carbon dioxide and waste products as well. And they also need that glucose to be converted into energy through aerobic metabolism. Without a lot of oxygen, an adequate amount of oxygen, anaerobic metabolism takes place, and you cannot meet the metabolic demands of the cells in that case. That's not good. Now, the body will work on not using oxygen in certain places. It can work off of anaerobic metabolism for a very short period of time, but it's a very short period of time. Okay, so I know we're about to get into patho of respirations, but that's like 7 slides and it's 6:52. So I'd like to go ahead and take a quick 10-minute break. And while we are waiting, maybe Chris will be here. He may actually already be here and I have missed him coming in. But what I like to do is I always tell my students that when my camera comes back on, then that means that we're back. So before we go to break, I'm going to go ahead and put on my 10-minute timer, and you guys go take a little 10-minute break. Go walk away from your computer for just a few minutes, okay? Okay, guys. I am going through emails as we speak, so I'm trying to get to everyone as I'm moving along, and I'm going to be reaching out to you guys probably tomorrow and the next day on some of your questions. But past that, let's get right back into the swing of things. And I see that our advanced EMTs are going to stay with us, and I'm really pleasantly excited about that. So do you guys remember me telling you just a few minutes ago that there are these receptors that are inside of the heart, and they're inside of our carotid bodies? These are going to be chemoreceptors. And it's actually the one inside the heart is at the top of the aortic arch. And there's a reason for everything in the body. But what these chemoreceptors monitor is going to be oxygen, carbon dioxide, hydrogen ions, and pH of our cerebral spinal fluid. And they're in other places too, but for our cardiovascular system, those are the two main ones. And what these do is whenever like serum carbon dioxide, hydrogen ion levels increase, those chemoreceptors are going to stimulate our medulla and it's going to increase our respiratory rate. Why? Because we're trying to get rid of all of that carbon dioxide, that hydrogen ion out of our system. And stimulation from the pons affects the rate and the depth of the respirations. And so the medulla and the pons are all in the back of the brain, and that's where that comes from. It's the reticular activating system. You don't really know all that right now, but moving right along, those chemoreceptors are what help us breathe and continue to breathe. And it also helps with our rate and depth. Okay, ventilation, perfusion, ratio, and mismatch. Okay, so your ventilation and perfusion must be directed to the same place at the same time. So air and blood flow, both same place, same time. Failure to match your ventilation and your perfusion is the cause of most abnormalities in our oxygen and carbon dioxide exchange. So we're going to talk about that next. Gas exchange doesn't take place when this happens. We're compromised. Maybe the alveolar membranes aren't working right. Maybe something's wrong with the blood. Whatever the case may be, it's gas exchange isn't working out. And like I said, CO2 is recirculated within the bloodstream at that point. And when that happens, what are we doing? Well, there's no oxygen getting where it needs to go. Our bloodstream is already full of carbon dioxide and whatever the waste products are. So there's really not a whole lot going on, right? So now perfusion across the alveolar membrane is disrupted. It's prevented. So now we have severe hypoxemia that occurs. Hypoxia is lack of oxygen. And so severe is even worse, right? So what are some of the factors that can affect our pulmonary ventilation? Okay, well, we have intrinsic factors, meaning inside the body, right? So infection, that's definitely one. Allergic reactions, that's one. Unresponsive, maybe the tongue is obstructing the ability for the airway to even work, and therefore respirations can't take place because ventilation can't take place. Okay, and the extrinsic factors, the ones that are on the outside, that's going to be your trauma. Let's talk about affecting respiration. We have external factors such as an atmospheric pressure, partial pressure of oxygen in the ambient environment. Remember, we talked about going into higher altitudes. That's one. Internal factors, that could be pneumonia. It could be pulmonary edema and COPD, emphysema. And what this is that surface area of the gas exchange, it's essentially decreased the blood's ability to receive oxygen supply. And so when that happens, that leads to inadequate tissue perfusion later on down the road. Circulatory compromise, you have obstruction of blood flow to the individual cells and tissues, can be related to the trauma emergencies, such as a simple tension pneumo, an open pneumothorax, a hemothorax, and then the hemopneumothorax. And you're going to go into all of those later on, more in definition. Okay. Other causes can be blood loss, anemia, hypovolemic shock, and vasodilatory shock. Okay, AGPs, aerosol generating procedures. Think about your CPR, nebulized treatments, endotracheal intubation, CPAP, or continuous positive airway pressure. And this, what this is, wear a mask, protective eyewear, whenever, and even like eye shields, whenever there's going to be like some sort of an airway management, including the aerosol generated procedures. Okay, so let's recognize our adequate breathing. Remember, I told you last chapter, there's some stuff you got to memorize. An adult, 12 to 20 times per minute, right? Here it is again. Regular pattern of inhalation and exhalation. Do they match? Is it bilateral? They're equal, clear lung sounds. Is it regular chest rise and fall? Is it an adequate depth or tidal volume? These are the things that we're going to ask ourselves. Abnormal breathing is anything below 12, more than 20. An irregular rhythm, diminished, absent, or noisy auscultated breath sounds, and reduced flow of expired air at the nose and the mouth. Unequal or inadequate chest expansion, increased effort of breathing, shallow depth. Skin is pale, cyanotic, remember that's blue, cool, moist. Skin pulling in and around the ribs or above the clavicles during inspiration, also called retractions. Okay, so a patient may appear to be breathing after the heart has stopped. We call this agonal gasp. You'll hear them called death rattles, agonal breathing. As a matter of fact, usually you won't see death rattle on a test, but you might. So that's just something that used to be called back in the Stone Age when I first took my EMT. But now you have something called, which we had this too, but Cheyne-Stokes respirations. These are seen in patients that have the strokes and head injuries. And the reason for it is because in your brain, where the pons and medulla are, they're kind of at the bottom of the brain. Well, the brain sits inside of your skull, right? And we're going to do an A&P lesson here real quick. So at the bottom of your skull, you have this nice hole. It's called the foramen magnum. And if there's like a lot of trauma to your head, you know, if I hit my arm, I can swell up, right? But if I hit my brain, it can swell up, but it's not going to go anywhere. It's going to go down. It's going to go through the foramen magnum. Same thing happens with a stroke too. So you will see that the pons and the medulla are going to shift downward through the foramen magnum. And when that happens, it's going to cause Cheyne-Stokes respirations. And this is what it looks like. And it's breathing with an increased rate and depth of respirations followed by apnea. So it'll be just this irregular respiratory thing, okay? Ataxic respirations, this is a regular and unidentifiable pattern, and that's going to be your more serious head injuries. As it continues to move down, you're going to have ataxic. Kussmaul's is different. This is going to be metabolic acidosis. Hold up, what? Okay, so we're going to just pump our brakes and say diabetic patients, okay? Especially the ones with really high sugar, okay, really high glucose levels. These are the ones that we're going to see those Kussmaul's respirations, and it's deep and it's rapid respirations. And why? Because in the body, when we have metabolic acidosis, and we look at carbon dioxide as a hydrogen ion, and that's considered an acid, well, we're going to breathe that acid out. So remember, we talked about how oxygen comes into the body, moves over into the capillary blood, and the capillary blood says, hey, alveoli, here's some carbon dioxide. Well, we do that, but it's deep and it's rapid. And patients with inadequate breathing need to be treated immediately because they're not getting correct oxygenation, okay? So assessment of respiration, even though the patient may be ventilating appropriately, respirations may be compromised. Level of consciousness and skin color are excellent indicators of respiration, guys. If someone is, yes, of course, level of consciousness. If they're anxious, that's your very first sign and symptom or your very first sign saying, hey, there's something going on. They're really anxious. They can't get enough air or whatever the case may be. If there's bluing of the skin, maybe they're pale, maybe they're moist. So those are your first ones. Also consider oxygenation. Pulse oximetry is considered a routine vital sign. And that's going to be the percentage of hemoglobin molecules that are bound in the arterial blood. And it's going to just measure that hemoglobin saturation. Your SpO2 is always supposed to be like 94% and above in conditions like your stroke, heart attack, things of that nature. It may end up being less than 94%. Okay. And this can be used as part of your patient assessment as well. You want to make sure that it is part of your routine vital signs. All right, so end-tidal CO2 is going to be the measurement of the maximum CO2 at the end of an exhaled breath, okay? That's the definition. Low CO2 level could be caused by hyperventilation, decreased CO2 return to the lungs, reduced CO2 production at the cellular level. It could be a high CO2 level may be indicated when you have your ventilatory inadequacy or apnea. And this is measured using capnometry and capnography devices. So those two are going to go hand in hand, and 35 to 45 millimeters of mercury is your normal. And it can be used spontaneously breathing patients with a special nasal cannula. And the other part of the nasal cannula will screw into whatever monitoring device you have. Okay, so let's talk about opening our airway. Okay, that's the first big thing, right? So emergency medical care begins with ensuring an open airway, right? Rapidly assess. If this patient's unconscious, go ahead and open it to the position the patient correctly, and supine position is the most effective. Also, when we're dealing with this, we're going to think about if they have a spinal injury. Am I going to use a head tilt chin lift, or am I going to use a jaw thrust maneuver? And so as a unit, you are going to move unconscious patients. And remember that tongue is just going to relax back, and it's going to stop all of the respirations, or all of the oxygen and carbon dioxide breathing to stop, right? Now, head tilt, chin lift is exactly what it sounds like. You head tilt and chin lift at the same time. And as you can see, she has her fingers on the chin itself, her hand is on the forehead, and she is literally moving the head this way. That's going to open the airway in a lot of our patients, and these are the ones that don't have any suspected trauma. Okay, follow these steps. Patient supine, position yourself beside the patient's head. Place the heel of one hand on the forehead and apply firm backwards pressure with the palm. And then you're going to take your fingertips and hand under the lower jaw and lift the chin upward. Okay. Once again, we're thinking about, hey, there's trauma involved, maybe some C-spine injuries involved. We're going to do our jaw thrust maneuver. This is when we kneel above the patient's head. We're going to place our fingers behind the angles of the lower jaw, and you're going to thrust or move that jaw upward. Use your thumbs to help position the jaw. All right, opening the mouth. Even if the airway is open, the mouth may be closed. So you're going to do a cross finger technique. I can't tell you how many times I've had to do this with unconscious patients. And it's literally, you're going to take your fingers and just make it into an X or a K. So you're going to place the tips of the index finger and thumb at the patient's teeth, push your thumb on the lower teeth, and push your index fingers on the upper, and then you're just going to crisscross your thumb and your forefinger. And here's the jaw thrust maneuver, figure 11-25. It's in your book. Go ahead and look at it. I'm going to talk about some suctioning now. Suctioning is super important, okay? When we're clearing the airway, we got to get it as clear as possible. However, we don't want to take away all of the oxygen that may be in that negative space. So for an adult, we're not going to do any more than 15 seconds of suctioning when we're trying to clear the airway. So, and then you guys can read figure 11-27 on the suctioning equipment. The first one is a handheld. The second one is in the truck, and the third one is going to be our portable unit that you're going to see a lot of. All right, the portable or fixed unit should have the wide bore, thick-walled, non-kinking tubing. It should have a plastic, rigid pharyngeal suction tips called yonkers, or it can be called a Ducanto catheter. I've never heard of that actually until I read it just now. That's not a joke. Best kind of catheter for infants and children, and the larger diameter plastic tips are rigid and they don't collapse. So your non-rigid plastic catheters, those are going to be called your French tips or whistle tip catheters, and those are used to suction your nose and even liquid secretions kind of in the back of the mouth. Then you have the non-breakable disposable collection bottle, and that's that big one, that big sucker, and it literally gets all the contents, okay? Then you're even going to have your water supply for rinsing the tips. So before inserting any catheter, measure for the proper size, and the way to do that is if we're going in the oropharynx, we're going to measure the same way we would do an OPA, and for you EMTs, we haven't gone over that yet, but you're going to go from the corner of the mouth to the tip of the earlobe, and so that's where we would measure. And it's the same thing with the tips, and use the same technique as measuring for OPA, and even MPA would be from the nose to here, but we're not talking about that yet. Okay. So techniques in suctioning, we're going to inspect everything regularly, make sure it works. Assemble everything, turn on your suctioning device, make sure it's no more than 300 millimeters of mercury, and just go ahead and select what's appropriate and go for there. We're never going to suction the mouth or the nose for more than 15 seconds at a time for adult patients, no more than 10 seconds at a time for children, and no more than 5 seconds at a time for infants, because this can result in hypoxia. So you guys need to know this now. Go ahead and memorize it, jot it down, highlight it, whatever. You'll see this on a test. You're going to see it on a quiz. You're going to see it on a, you'll see it on the quiz. You're going to see it on the test. You may even see it on National Registry. Okay. So you need to know this one. When patients have secretions or vomit that cannot be suctioned easily, we're going to go ahead and remove the catheter from the patient and log roll them to the side and let gravity help us, okay? And clear the mouth carefully with a gloved finger. If the patient produces frothy secretions, as quickly as you can suction them, we're going to suction for 15 seconds, obviously 10 for children, 5 for infants. Ventilate for 2 minutes. Because at this point, even though there's a lot of obstruction that's there, we got to get some oxygen into them. We have to have some form of ventilation and then possible respiration take place. Then we're going to continue alternating that pattern. So basic airway adjuncts. Now here we go. I talked about OPA just a minute ago, guys. So for you EMTs, an OPA is an oropharyngeal airway, and this is going to keep the tongue from blocking the upper airway, and it also makes it a lot easier for us to suction. Indications are in unresponsive patients without a gag reflex. Very important, extremely important. Without a gag reflex. Do not ever put an OPA in a patient that is even semi-conscious. That's very bad. Apneic patients being ventilated with a bag valve mask. So anyone that's in cardiac arrest. Contraindications, conscious patient, and any patient who has an intact gag reflex, because even if they're unresponsive, sometimes they might have a gag reflex. Nasopharyngeal airways, those are the ones that are going to go in the nose, and these are used for patients who are unresponsive or have an altered LOC, level of consciousness, has an intact gag reflex, and is unable to maintain his or her own airway spontaneously. It's indicated in semi-conscious or unconscious patients with an intact gag reflex. That's good. And it's patients who just won't tolerate that OPA. And usually it's kind of C reason 1 why, okay? Contraindications is severe head injury with blood in the nose and or history of fractured nasal bones. Now, the reason for it is because when the nasopharyngeal airway goes into the nose, it can, in fact, go into the skull if there is a fracture there. And no one wants to put oxygen inside the brain, not directly, okay? Now, let's talk about maintaining our airway. Recovery position is awesome. Okay, we use this in a lot of different patients, especially ones after they've had a seizure, and we know that there's not really a whole lot of trauma associated. So this helps maintain and clear our airway in our unconscious patients, and this helps them breathe on their own. And it's literally they're rolled left or right side, and you put that knee out, you put their arm underneath their face like so, and just allow gravity to help you. Let's talk about supplemental oxygen now. Okay, always give oxygen to patients who are hypoxic. Some tissues and organs need a constant supply of oxygen to function normally. So let's talk about a couple of those real quick. Your heart and your brain. They can't go without oxygen. It's not good. Okay, after 4 minutes of your brain not having oxygen, you start having irreversible brain damage. Okay, we don't want that. So we have to have a constant supply of oxygen to at least those 2 organs. Never withhold oxygen from any patient who might benefit from it, even if you don't know what their history might be. Let's say you run into a scene and the patient's unconscious and it looks like they're having respiratory difficulty and you don't know if they're COPD or not, and their SpO2 is like 88 on room air. Okay, if you don't know, give them oxygen, okay? All right. Okay, thank you. Never withhold oxygen. Okay. So supplemental oxygen equipment, oxygen cylinders contain compressed gas. So liquid oxygen, you're going to start seeing that more and more. Maybe not necessarily in the rural areas, but definitely in larger cities, you will absolutely see those. So we're going to check that the cylinder is labeled for medical oxygen. And you can look for the letters and numbers, and they are stamped on the collar of that cylinder. You're going to check the month and the year stamps, and that tells us when it was tested. And you want these to be tested. You want to know that these are good. They're every 5 years, and then your composite cylinders are every 3. You're going to mostly see your D-size cylinders. Those are our portable tanks. And so depending on the size of our tanks will depend on how much oxygen you're going to get out of them. So let's talk about some safety considerations when dealing with these oxygen tanks. First off, we have to handle them very carefully. Its contents under pressure. You don't want those guys bouncing around in the back of an ambulance, and you don't want to be accidentally kicking them over or them falling off the stretcher when you're dealing with a patient. That's not okay. Any type of puncture or hole in the tank, it can become a missile. That's a legitimate thing. Oxygen cylinders, so you're just going to secure those when stored in the ambulance and during transport. Okay. Now you have something called the pin indexing system, and this is going to ensure that you are only going to be able to put an oxygen regulator on an oxygen tank. And it's just going to prevent you connecting to maybe a carbon dioxide cylinder or any other type that may be out there. And you guys can read up more about that. Pressure regulators. So you have a therapeutic range between 40 to 70 psi. Your final attachment for delivering the gas is either through a quick connect female fitting or a flow meter, and that will be in the back of your truck or on the regulator itself. Your flow meters are usually permanently attached to pressure regulators, and you have pressure compensated flow meters and board and gauge flow meters, and there should be a picture in your book somewhere to tell you which ones are which. So let's talk about some hazards. Obviously, combustion and oxygen toxicity. So there are going to be patients that you're going to see that are still smoking cigarettes. They're still connected to oxygen. That's no bueno. That's actually very, very, very bad. And yeah, that they can catch on fire. That's not a joke. I've been to a couple of calls like that. It's quite sad. And then oxygen toxicity is another thing. So check out Skill Drill 11-7 in your book to talk about how to administer oxygen to a patient. Oxygen does not burn or explode, but it does speed up the combustion process. So keep any source of fire away. Obviously, try to tell people like, hey, you need to quit smoking. Well, don't try. Just tell them you got to quit. You can't do this. Make sure that the area is adequately ventilated and never leave an oxygen cylinder standing unattended. That's really bad. Let's talk about oxygen toxicity. Not all patients need that high concentration of oxygen. Remember, we talked about them already, COPD patients. Okay, so oxygen can have a detrimental effect on these patients. When pulse oximetry available, tailor your oxygen therapy. Administer the minimum amount necessary to maintain oxygen saturation at or above 94%. Okay, and in some of these people, they may only have like an 88%, and that is okay. They don't have to have, and I keep using the word 88, and that's okay, but that's a pretty one. You'll see that a lot in the field. So oxygen delivery equipment, we have our non-rebreather mask, we have a bag valve mask, or a BVM, or nasal cannulas, and each one does something different. So let's go over our non-rebreathers. And those are the mask and the reservoir bag system. It's a preferred way to give oxygen to people that are suspected of having a bit of hypoxia, but they're breathing pretty adequately. And so what you'll do is you'll depress a little spot right there in the middle of the mask, and you will fill the reservoir bag with oxygen in a one-way valve. And then you're going to put that over your patient. But that exhaled gas escapes through the flapper valve port at the cheek areas of the mask, and it just prevents that patient from rebreathing any exhaled gas. Make sure the reservoir bag is full, because if not, they're not getting any oxygen. So you're effectively taking away all their air. adjust the flow rate so that it doesn't collapse. These are going to be between 10 and 15 liters of oxygen. And when oxygen therapy is discontinued, just remove that mask. Okay, so this is a nasal cannula, and it's through 2 prongs that fit into the nostrils, and it can provide up to 22 to 44% inspired oxygen when the flow meter is set at 1 to 6 liters per minute. And this is really mild hypoxia or hypoxemia, and a lot of patients who breathe through the mouth or have like some sort of nasal obstruction, they're not really going to benefit. So if you have somebody that you're already on scene and they're already mouth breathing, a nasal cannula is just not going to cut it. When you anticipate a long transport time, you consider using humidification or humidified oxygen. I've only seen maybe a couple of transfer trucks, so to speak, that have humidified oxygen, like in their trucks and ready to go already, but it's not something that you can't carry. Portable rebreathing masks is similar to our non-rebreather, but there's no one-way valve between the mask and the reservoir. And so they are going to get a little bit of that exhaled air. Okay, so here's a Venturi mask. I've been teaching about Venturi masks for 17 years now, and I've never seen one on an ambulance, but that doesn't mean that it's definitely not in Mississippi that I have seen. I'll say that. That doesn't mean that it's not in other areas of America. So remember, we teach to the level of everyone in America, the national level. So the Venturi mask has a lot of different attachments, but it's going to maintain that constant flow of oxygen, and it's going to deliver between 24 to 40% of oxygen. Now we have patients with trachs or tracheostomies. They don't breathe through their mouth or their nose. They're going to breathe literally through their tracheostomy. As you can see here in this picture 11-42, that there's a non-rebreather or a mask. It's not really non-rebreather, it's just a mask laid on top of the tracheostomy. Okay. And this actually is that a tracheostomy mask? I can't tell. I'm sure it is. But when you're in rural Mississippi, you make do with what you have. But they do make tracheostomy masks for this reason, and it covers the hole, and then the straps will go onto the tracheostomy itself. It's held in place by a collar, and so their straps will go around that neck as well. And but they may not be available in emergency settings, so you can use a regular mask, face mask, or if you don't have one of those, you can use a non-rebreather. Just make sure that the bag is filled up. So, assisted and artificial ventilations. Okay, so we have basic airway and ventilation techniques, extremely effective. We've been doing them for years with just slight modifications through the years to make it better. So what are some of our signs and symptoms of inadequate ventilation? Altered mental status. Remember, I told you anxiety is like their very, very first one, but it could be a lot of other things like altered level of consciousness, inadequate minute volume. What if they have excessive accessory muscle use and fatigue? You know, you go to a patient and they say, I am tired of breathing intubating. That's the person that you're like, oh, okay, hold on, got you. And you already know what you have to do. When assisting with a BVM, bag valve mask, and this is a bag mask device, but I'm going to put the V in there because that's what I normally use. Explain the procedure to the patient. Place the mask over the nose and mouth. This is if they're conscious naturally. Squeeze the bag each time the patient breathes. And after that initial 5 to 10 breaths, deliver an appropriate tidal volume. So what does this mean? So as we are putting the mask over the patient's nose and mouth, if they're taking shallow breaths, we're only going to take the shallow breath with them as they're breathing. Then after those first 5 to 10, now we're going to make them breathe in a little bit more, what should be a normal tidal volume. Remember, tidal volume is about 500 mLs, okay? All right, once a patient is not breathing, we're going to go ahead and begin what's called artificial ventilation. And this is via the mouth-to-mask technique, and that's with a pocket mask or a 1 to 2 person BVM device. Normal ventilation versus PPV or positive pressure ventilation. In normal breathing, remember that diaphragm contracts, negative pressure is generated in the chest cavity. So we have, that's the active portion of breathing, right? Well, if they're not conscious or alive, none of that's happening. So PPV, or positive pressure ventilation, is generated by a device that forces the air into the chest cavity. It increases the intrathoracic pressure, and it reduces reduces the blood pumped by the heart. More volume is required to have the same effect as normal breathing. So as air is forced into the stomach, and it can cause our gastric distension. So you have to be really careful when dealing with one of these. And one of the most common mistakes is not holding the patient's airway open correctly. And that's why you have so much more that will go into the stomach. And this is going to drop our cardiac output because there's going to be even more pressure on our aorta, and the intrathoracic pressure will stop the heart from pumping correctly. Okay. Now, in an adult, this is one breath every 6 seconds. In a child, it's one breath every 2 to 3 seconds. And in an infant, it's one breath per 2 to 3 seconds. So mouth to mouth or mouth to mask ventilation. So there's a barrier device that you can use. And this is just a mask with oxygen inlet provided, but you can use it just as you still will put your mouth on the device itself. And there should be a picture of it somewhere in your book to kind of explain more. But it's just got a little inlet on the side of it where you can put your tubing. This is what a BVM looks like, a bag valve mask. And I keep saying valve, and I'm not even seeing it in here for the valve. So apparently I missed that when they updated the edition. So bag mask provides less tidal volume than a mouth to mask ventilation. And an experienced EMT can provide adequate tidal volume. So you're going to practice this a lot. Okay. There's no pop-off valve. There's an inline viral filter. So this is going to help. There's not going to be any non-rebreathing. This allows for that the reservoir is going to hold more oxygen. So we're going to get a higher concentration of oxygen. And this is a one-way, no jam inlet valve system that provides oxygen flow rate at a maximum of 15 liters per minute. And there's the standard 15 to 22 millimeter fitting for the face mask. So you can even use this with the with your endotracheal tubes and even other advanced airway adjunct connectors. And go to skill drill 11-8 to show more. All right, gastric distension. So we have this that occurs when artificial ventilation fills the stomach with air. Remember, we talked about this just a minute ago. I told you most likely it's going to occur when you ventilate the patient too forcefully, too rapidly, or even when the airway is obstructed, such as when you don't open the airway appropriately. So be careful of that. Gentle, slow, artificial ventilations delivered over 1 second is going to be the best bet for you to stop gastric distension from happening. Did I go too far? I did. Sorry. To prevent or alleviate distension, ensure the patient's airway is appropriately positioned, ventilate at the appropriate rate, ventilate at the appropriate volume, and if the stomach appears distended, recheck and position the head to perform rescue breathing. So once again, I'm going right back to that whole thing of, hey, if you're not holding the airway, the airway open correctly, you're going to cause even more gastric distension. Now, what happens if the patient vomits? Well, turn their entire body on the side, suction, wipe all that stuff out, and start back over again. And that's really what's going to happen if you, and I will tell you this, a little side note for someone who's been in the field for years and has done this, seen this, and I promise you that any of your other instructors can tell you this as well. When you bag someone, that's what we call it when we are giving, when we're using a BVM. When you do that too forcefully, and you do cause gastric distension, first off, you're gonna have to go back to the station and change your pants. Second, that smell is like no other. So you'll only do it once. And I hope that you don't have to go through that. Please learn from our mistakes from previous ventures. But we were all new once upon a time, and a lot of people do that their first time. So if you hear somebody on scene saying, hey, slow down, That's what we're trying to prevent you from having that happen to you. Okay, assisted and artificial ventilation. Okay, passive ventilation. Expansion and contraction create a pump for air movement. So benefits patients who are receiving chest compressions and can be enhanced during using your OPA and supplemental oxygen. So remember, as that chest recoils following a compression, that there's a negative pressure that's created within the chest, and that's going to result in a vacuum. So air is actually sucked into the chest cavity at this point. And so it's kind of like a mock contraction of the muscles during active ventilation. But passive ventilation can be enhanced by inserting that OPA. So now we have ATV, or automatic transport ventilators or resuscitators. And these are the ones that they have a control box that allows different variabilities of ventilations. It frees the EMT to perform other tasks such as mask to seal, including airway patency, but it lacks the sophisticated control of a hospital ventilator. And so with that, you have to have a constant reassessment of the patient. Now, here's a non-invasive ventilatory support for respiratory distress, and this is called your CPAP, or continuous positive airway pressure. Many people diagnosed with obstructive sleep apnea wear a CPAP unit at night, but hey, it's being used by EMTs, AEMTs, and paramedics, all the like. And we're learning how to save people's lives with this thing. So what is its mechanism? Well, it increases pressure in the lung, it opens up your collapsed alveoli, and it pushes more oxygen across the alveolar membrane. Remember, if there's some sort of an obstruction, like let's say in this particular case, I'm glad, Michael. In this case, we have fluid in our alveoli. That's considered an obstruction, because if there's fluid in the alveoli, guess what? You can't get oxygen past fluid. So if I have continuous positive pressure going through, it's pushing all of this fluid down into the capillary bed, down into the capillary bed until there's no more fluid. And now I can get oxygen across that alveolar membrane. So this is what's happening. And all of that goes back into the interstitial space, okay? Therapy is delivered through the face mask held at the head with a strapping system. By the way, practice using that. The first time I had to use it, I had no idea what I was doing. It was a complete fail. Thankfully, I had a partner that had used it before, and he really bailed me out. So even as a paramedic, sometimes, we make mistakes. And it's okay. So if you get a new piece of equipment, and I have been in the field long enough for CPAP to be a new piece of equipment, that just made me feel really old. Make sure you know how to use it, okay? Okay, use cautions with patients with potentially low blood pressure, and you want to make sure that they can also follow directions. This is a big thing. They can't follow directions. If they cannot swallow, you should not put this on this patient. So indications: patient is alert and able to follow commands, displays obvious signs of moderate to severe respiratory distress. The respiratory distress occurs after a submersion incident. So if it's a near drowning, patient is breathing rapidly and the pulse ox is less than 90%. And those are obvious signs. So here's some contraindications. Patient is in respiratory arrest. That's not going to help anybody. Patient is hypoventilating. That's not going to help anything. Patient can't speak. What's the underlying issue here? We've got to fix this. They can't speak. There's something else going on, okay? Let's see. Patient's unresponsive. Can't follow verbal commands. Patient cannot protect his or her own airway. And patient has hypotension. Signs and symptoms of a pneumothorax or chest trauma. So if you have chest trauma and they have a pneumothorax, which is essentially a hole in the lungs, and you're pushing excessive air through there, do you think that's going to help anybody? No, that's just going to cause more damage. Patient has a tracheostomy. We're not going to do it with anybody with a tracheostomy, period. Active GI bleeding or vomiting. That's a really terrible idea. Patient has experienced facial trauma. Why would you put a mask on a person's face that has facial trauma? It just doesn't make sense. Patient is in cardiogenic shock if you're excessively putting more and more oxygen into an area and filling it up, but your heart has been the issue. What do you think is going to happen with the heart? It's going to decrease the pressure of the heart inside of the mediastinum. So that's another reason. Patient can't sit upright. Your patient has to be sitting upright to have this, and patient cannot tolerate the mask. So application. So there's several different components. You have your generator mask. You have a circuit containing the corrugated tubing, bacterial filter, one-way valve, and all of these are included. Now, the CPAP generator creates resistance throughout the respiratory cycle. This resistance creates that back pressure that pushes open those smaller airway structures such as your alveoli, and then the patient has an ability to, as the patient exhales. So the amount of pressure can definitely be determined by adjusting a valve within the CPAP system or with a separate valve that can be attached. So a pressure of 7.0 to 10.0 is generally acceptable in the therapeutic range. Most CPAP units are powered by oxygen, so it's important to have a full oxygen cylinder when using CPAP, and I promise you, you will run out of oxygen quicker than you think using a CPAP. So go and follow Skill Drill 11-9 to learn a little bit more. So there are some complications that you may end up running into, like claustrophobia is a big one. And that's like the small spaces or something surrounding the face. There could be a risk of pneumothorax. So high pressure in that chest can lower the patient's blood pressure. We've already talked about that. If the patient shows signs of deterioration, go ahead and remove the CPAP and begin PPV using a bag valve mask at that point. Now, let's talk about special considerations. And guys, we're almost done. So we have stomas and tracheostomy tubes. So patients who have a laryngectomy have a permanent tracheal stoma, which is the opening of the neck that connects the trachea directly to the skin. And that is what that looks like right there. Neither the head tilt chin lift, jaw thrust maneuver is required at this point because we don't have to worry about moving the tongue out of the way. We're not even doing anything here, okay? So if the patient has a trach tube, ventilate through the tube with a bag valve mask. If the patient has a stoma, but there's no tube in place, such as that first picture, use an infant or a child mask with your BVM mask to make a seal over the stoma. That's right, you're going to open up two different bags, and you're going to use the mask from a child or an infant BVM, but you're going to use the adult BVM, the thing that you're squeezing, okay, the bag itself. If you can't ventilate the patient with a stoma, try suctioning because it's normally going to be a mucus plug that's there, and seal the stoma while giving mouth to mouth. So when we're suctioning, we're going to try to suction the stoma with a French tip or a soft catheter. And remember, when we talked about adults being no longer than 15 seconds, you're actually going to back that up a little bit because we're not dealing with this area right here. So we're going to do to 10 seconds. All right. Let's talk about foreign body airway obstructions, or FBAOs. And those are the ones that completely block the airway. It's a true emergency. They're going to die if they don't get treated. Usually this happens in a meal with adults. Of course, children, they're crawling around and they're playing, and that's when this happens for the most part. Tongue is the most common cause of an airway obstruction in your unconscious patient, but other causes that do not involve foreign bodies, swelling. You can have that from an infection or acute allergic reaction, and sometimes even trauma. And you'll see that too. Your mild airway obstruction is going to be when they can still exchange air, but they have some respiratory distress. So it's going to be like more of the wheezing and the stridor, some coughing, maybe something in that nature. And they'll have good air exchange, so don't interfere with the patient's effort to expel whatever that object is. Just leave it there. Thank you, Mark. With poor air exchange, the patient may have increased difficulty breathing, stridor, and cyanosis. Now, remember, we talked about how wheezing is in the lungs, stridor is right here. This means the obstruction is between here and here, because you're going to hear it audibly from here to here, okay? and go ahead and treat immediately. Now, this is severe airway obstruction. This is the one that's like, they're like, oh gosh, I can't breathe. They're not talking. This is just what I would think they would be saying. Yeah, I'm the same way with mucus plugs. I agree. I guess I made that face on. I am so sorry, y'all. I cannot say what I'm thinking, but I cannot deliver the face from evil, so I apologize. These are the patients with the severe airway obstruction, can't talk, they can't breathe, they can't cough, they can't do anything. And anxiety goes through the roof immediately. And they're going to use that universal distress signal. And it's universal because we all know what this means. I'm choking. So that's why it's universal. I'll provide immediate treatment to your conscious patients, and we know how to do that, right? We know what to do. Anybody want to tell me what we do? It's probably on the slide somewhere. What do you do in a patient that has a severe airway obstruction, but they're conscious? I'm trying to wake y'all up. I know we're almost done, but come on. Somebody put it in the chat. There you go. Heimlich maneuver. Thank you, Lewis. All right. Now, Lewis knows. My advanced EMTs don't know this, but I'm going to tell you, I'm here till 10 p.m. Okay, so the more y'all answer, the quicker this goes, because I will wait. I have nothing better to do other than eat. You didn't spell it right, but I knew what you meant, and that is totally fine. If you're going to make a mistake in class, make a mistake in class, and don't pick on anybody. That's just rude and unnecessary. So if not treated, your patient's going to become unconscious and they're going to die. And so what do we do then? We have to begin CPR. And we really want to worry about doing that high quality chest compression with these patients. Why? Because we already know that they're choking. We already know that there's an airway obstruction. So are we going to be doing a whole lot of rescue breathing? No. High quality chest compressions, okay? Yeah. So let's talk about performing the head tilt chin lift, clear that tongue obstruction. Larger obstruction should be swept forward out of the mouth with your gloved index finger, and abdominal thrusts or Heimlich maneuver are the most effective method of dislodging and forcing out an object. Dental appliances. Oh boy, these are terrible. They will go in the back of the throat, and in some cases, you just lose them. So if you see a dental appliance that is trying to become dislodged during CPR, go ahead and remove that immediately. So examples, of course, are your crowns, bridges, pieces of braces. It can be just dentures. If they are well fitting, leave the dentures in place, because once you remove the dentures, you don't really realize when you're doing when you have a bag valve mask on a patient's face, you don't really realize how much of structure the teeth actually give. And so you want to leave those in place as long as possible. Loose dentures, though, get them out of there. Let's talk about facial bleeding. Of course, that can cause an airway problem. It can be a huge issue. So the blood supply to the face is extremely rich. You can have a 1-inch laceration on your forehead, and it looks like you have just gone through a murder scene. It's terrible, because a 1-inch laceration here versus a 1-inch laceration here are going to bleed completely differently. And it's just because of the fact that the face is such a rich blood supply. So if you have any severe tissue swelling, bleeding into the airway, remember all of this is like super rich with blood, and control bleeding as much as you can with direct pressure and suction is necessary. All right, so placement of advanced airways. You're going to first, when your critical patient needs your advanced airway intervention, the paramedic and even advanced EMTs will perform certain things, okay? So such as, first thing is we're going to pre-oxygenate, and then we're going to have our equipment set up, whatever it is, especially if it's like we're going to go through ET tube, okay? First step, maintain that high flow oxygen. And we're going to perform these next procedures called B Magic. Perform bag valve mask pre-oxygenation, evaluate for airway difficulties. Manipulate the patients. What does manipulate mean? Well, that means we're gonna maneuver them the way we need them to, right? And we're also going to use like suction and things of that nature. We're going to use our laryngoscope handle and blade, even maybe some McGill forceps at this point. Then we're going to have our attempt at first pass intubation. And sometimes you have to use a supraglottic airway if unable to intubate, because we don't want to continue to do something that we couldn't do the very first time. That's why we call it attempt first pass. And then C is confirm successful intubation or correct any issues that you may come into contact with. All right, let's do our review. Once again, let's see, I have 38 people in this class. So that means a minimum of 10 have to answer these questions before I will move on to the next slide. And there's about another 30 slides to go, and it's 7:55 p.m. and we're not taking a break. So y'all get ready. ABCs. There you go. Thanks, Chris. I appreciate it. A, B, C, or D. All right, you ready? Let's go. Breathing is controlled by an area in the A, lungs, B, brainstem, C, spinal cord, or D, diaphragm. Let's go over that one more time. And it's okay to be wrong. Be wrong here, not out there, okay? Breathing is controlled by an area in the lungs, brainstem, spinal cord, or diaphragm. Keep it coming. I got only 3 of you. Come on, guys. 3, 4, 5, 6. I only got 6 of you. Come on. 6 out of 38. That's not great. All right. Okay. Y'all taking it seriously. Good. The answer is B. A lot of you guys got it right. The pons and the medulla are the respiratory centers of the brainstem that control breathing. So, B is just the correct answer. It's in the brainstem. The lungs contain small pockets of alveoli where the exchange of oxygen and carbon dioxide do take place. The spinal cord, that's just impulses. And the diaphragm, it's once again the impulses that cause it to contract. So good job, guys. I'm going to put B in here because I'll be able to know how many people are answering on the next one. All right, number 2, the EMT should assess a patient's tidal volume by A, observing adequate chest rise, B, assessing the facial area for cyanosis, C, counting the patient's respiratory rate, or D, measuring the patient's oxygen saturation. Number 2, the EMT should assess a patient's tidal volume by A, observing for adequate chest rise, B, assessing the facial area for cyanosis, C, counting the patient's respiratory rate, or D, measuring the patient's oxygen saturation. Okay, let me get all these off of here so I can start looking. Okay, I had a question mark in here. You know what? I appreciate that. I really appreciate that. Saying I don't know is okay right now. Okay, so we're gonna learn. I have everything on here. I have A, B, C, and D. Okay, let's see what it is. The answer is A. Tidal volume is the volume of air that is moved into and out of the lungs in a single breath. So it's assessed by observing the chest rise adequately. If shallow chest rise is noted, the patient's tidal volume is likely reduced. This is something that we can look at and see if their tidal volume is adequate. So assessing the facial area for cyanosis is just indicating hypoxia. Doesn't necessarily mean tidal volume is good or not, because guess what? They can be hypoxic because they might have regular tidal volume, but what if there's an obstruction inside of the alveoli? Okay. Counting patient's respiratory rate. That's going to give you minute volume, not tidal volume, okay? And oxygen saturation literally just means tissue perfusion. It doesn't necessarily mean anything about your tidal volume. So good job, guys. Very good. Hold on just a second. Let me put that in the chat box as my answer. In an otherwise healthy individual, the primary stimulus to breathe is A, increased level of oxygen in the blood, B, decreased level of oxygen in the blood, C, increased level of carbon dioxide in the blood, or D, decreased level of carbon dioxide in the blood. This is tricky, and it's okay if you get it wrong. Just answer. Go with your gut. In an otherwise healthy individual, the primary stimulus to breathe is A, increased level of oxygen in the blood, decreased level of oxygen in the blood, increased level of carbon dioxide in the blood, or decreased level of carbon dioxide in the blood. I have A, B, C. It's about to start singing. Answer C, guys. Great job. Okay. Great job. Under the control of the brainstem, the rising level of the carbon dioxide in arterial blood normally stimulates breathing, saying, hey, I have a whole lot of carbon dioxide in here and not enough oxygen going to, I need to lower my carbon dioxide levels by adding more oxygen. So, and the rationale here, increased level of oxygen is actually a result of hyperventilation syndrome. A decreased level of oxygen in the blood in healthy individuals can be a sign of inadequate breathing, such as hypoxia. And decreased level of carbon dioxide in the blood, usually not seen in healthy adults, and it's typically a result of hyperventilation syndrome. Okay. All right. All right, so C is the correct answer there. All right, number 4, signs of adequate breathing in an adult include all of the following except A, pink, warm, dry skin, B, shallow chest rise, C, symmetrical chest movement, D, a respiratory rate of 16 breaths per minute. Read it one more time. Got a lot of B's coming in. Okay, signs of adequate breathing in adult include all the following except A, pink, warm, and dry skin, B, shallow chest rise, C, symmetrical chest movement, or D, a respiratory rate of 16 breaths per minute. Okay, how many I got here? Come on, guys. Come on. Let's answer. Let's go. I'm getting less and less each time. Getting a lot of B's. I got a D. I got a C. All right. So the correct answer is B. Signs of inadequate breathing in an adult include a respiratory rate less than 16 or greater than 20, shallow chest rise, that's that reduced tidal volume, cyanosis, and asymmetrical chest movement. Okay, so those are our signs of inadequate breathing. If you ever hear the word shallow, we're going to go ahead and automatically know that they are not breathing adequately. Okay, so all the rest of them are normal. Pink, warm, dry skin. I have pink, warm, dry skin. I have symmetrical chest movement, and I'm probably breathing closer to 20 times a minute because I'm talking a lot, but 16 is well within the 12 to 20 range. Okay, so, oh, hold on. It was B, right? Yeah. Okay. Thank you so much. I'm going to read out what Chris says. You guys got to understand she can and will make this way longer. And yes, thank you. I try to be full of great facts, and I am definitely ready to pass all of these on. Oh, great. I went straight to the answer. That's okay. Y'all didn't see A. Y'all didn't see that. Thanks, Brent. I see that. We're going to go over the question anyway. All right. During insertion of the OPA in an unconscious patient, she begins to vomit. The first thing you should do is, obviously, I left it on the slide. It's turn the patient on her side. Now, why did she do it? Stop putting A in the answer. Tell me why she did it. Go ahead. I'm going to guess A. Thank you, Jared. Thank you, Bailey, for the laughy face. Because she had a gag reflex. Thank you, Lindsay. I'm so glad I could make y'all laugh tonight. Yeah, that's true. That's true. She's going to choke if we do it the other way. Okay. Okay. Hands off. Number 6. All right. In which of the following patients would a nasopharyngeal airway be contraindicated? A, semi-conscious patient with a gag reflex. B, an unconscious patient with an intact gag reflex. C, a patient who fell 20 feet and landed on his or her head. D, an unconscious patient who gags when you insert an oral airway. So I'm going to say it one more time. In which of the following patients would an NPA be contraindicated? Semi-conscious patient with a gag reflex, unconscious patient with an intact gag reflex, a patient who fell 20 feet and landed on his or her head, or an unconscious patient who gags when you insert an oral airway. Okay, let's see. I have a whole bunch of C's. Do I have another C? Okay. The answer is C. Okay, Sydney, it's okay. It's okay not to know. This is where you're not, let me teach you. Got you, okay? All right, so nasopharyngeal airways are contraindicated in patients with severe head trauma or even facial trauma. Remember that, and I guess we really need to see a picture of one. I didn't see one in your slides. I know it's in your book. So go back and find the page that the nasopharyngeal airways are on, and you're going to see like a slight tip. Okay, and if you are inserting this into the nair, and I mean, if you can look at the cross section of the face, you guys already know that there's the skull's right here, and you're sticking something in the nose and it's going to the back. So it can go inside of the skull if there's a fracture there. And we don't know if there's a fracture there because we don't have x-rays in the back of the truck. Although it's 2024, I assume it's not much further along than that. So, and we need to have worry about patients that have delicate nasal membranes. They're prone to nosebleeds. The nasal airway is better tolerated in patients who are semi-conscious and or those with a gag reflex. So the airway works best with intact gag reflexes. That is a indication to use an NPA. And then of course the airway can be used in patients with a gag reflex and oral airway. So, very good. Number 7, you are delivering oxygen to a patient with a nasal cannula at 4 liters per minute when he begins to complain of a burning sensation in his nose. You should A, remove the nasal cannula, B, apply a non-rebreather mask, C, attach oxygen humidifier, or D, increase the flow rate to 6 liters per minute. Okay. You're delivering oxygen to a patient with a nasal cannula at 4 liters per minute when he begins to complain of a burning sensation in his nose. You should A, remove the nasal cannula, B, apply a non-rebreather mask, C, attach an oxygen humidifier, or increase the flow rate to 6 liters per minute. Okay, let's see what I got here. I got some C's, I got some B's, or I got a B. I think I saw a B. I may be wrong. Okay, all right. I understand where you're going with saying B, but the actual answer is C. So a burning sensation will happen when the nares are starting to dry out and crack. We don't want that to happen for our patients because it can also, not only is it a little bit uncomfortable for them, and it does cause that burning sensation, but those can dry and crack and then have a little bit of bleeding. So we don't want to do that. So we deliver humidified oxygen instead, so that that's over prolonged periods of time. And it's where our those nasal membranes are not going to dry out, they're not going to crack, and they're not going to cause any more problems. I can understand if you are saying, well, I would put them on a non-rebreather because I don't have humidified oxygen in the field. Nay. We are only in the book, and in the book, you have everything at your disposal. Everything you could think of, it's in your trunk. It's in your bag. Your partner is the best partner in the entire world. They know everything. This is National Registry, guys. So you are 1000% equipped, okay? You could, but the correct answer here, honestly, in real life, yeah. But are you going to be delivering too much oxygen? If this is a patient with COPD and you're just getting their SpO2 level a little bit higher than what it normally is because they're having some problems breathing, yes. But you don't want to leave that non-rebreather on for too long, if that makes sense. Because in the grand scheme of things, I would much rather you be upset with me because your nares are burning versus you're not breathing anymore. So it's one of those. So the correct answer here is humidified oxygen, okay? Versus the other one. And it even states here with the non-rebreather, it still can cause irritation because it's a dry oxygen. So keep that in mind. What did I do? What did I just do? I don't even know what I did. Okay, I'm back to normal. Sorry. I clicked something way wrong. Michael, you have a question. Go ahead and throw it in the chat for us. That way I can answer. I'm glad I could answer that question for you, Tammy. Okay. While Michael's trying to, yeah, go ahead.
Yeah, so my slides have been stuck on the second question. I've been participating the whole time. It's just the notifications blow up my screen and then I can't reply. And yeah, I just want to make sure that
okay,
you know that I am sorry, participating. It's just my screen is still stuck on the second slide. So
that's perfectly fine. You may want to get in and back out and get right back in. Okay. And that will, yeah. Okay. And you should be able to see it.
Right on. All right. Thank you.
You're so welcome. Okay. Number 8, a patient is found unconscious after falling from a 3rd floor window. His respiration's slow and irregular. You should A, place him in the recovery position. B, apply oxygen via a non-rebreather mask. C, suction his airway up for up to 15 seconds. Or D, assist his breathing with a BVM. Let's go back. Number 8, a patient is found unconscious after falling from a 3rd floor window. His respirations are slow and irregular. You should A, place him in the recovery position. B, apply an oxygen via non-rebreather mask. C, suction his airway for up to 15 seconds. Or D, assist his breathing with a BVM. I have a ton of D's. Let's see. All right. Keep them coming. I know there's more of you in here. Okay. Got a lot of D's. Ton of D's. D is the correct answer. Very good, guys. Okay. The patient is not breathing adequately. Slow, irregular respirations will not result in adequate oxygenation. So you are going to assist their respirations with a BVM at 100% oxygen, which is going to be 10 to 15 liters. Okay. So we're definitely not going to place them in a recovery position because they fell. Okay. Because if you place somebody in the recovery position, you're not worried about C-spine, and that's not okay. Okay. A BVM is indicated, obviously, because they're breathing less than 8 times a minute. We're not going to suction unless there's blood or other secretions that are in the airway. We weren't told that there was blood or secretions in the airway, so we're not going to worry about that. And then, of course, your correct answer is the bag valve mask. Okay, very good. All right, 2 more to go, guys, then I'll let you go. All right, when ventilating an apneic adult with a BVM, you should squeeze the bag, A, until it's empty, B, over a period of 2 seconds, C, at a rate of 20 breaths per minute, or D, until visible chest rise is noted. I did not actually go over this in class, so we're going to go over this, but I hope you guys get it right. When ventilating an apneic adult with a bag valve mask, you should squeeze the bag, A, until it's empty, B, over a period of 2 seconds, C, at a rate of 20 breaths per minute, or C, until visible chest rise is noted. All right. And apparently, I didn't have to go over it because you guys already know. Okay, D, maybe B. All right, now let's go through why. So over a period of 2 seconds, I can understand you saying that because of the the gastric contents and not gastric contents. I mean, it does have something with that, but the worrying about putting air into the stomach. We're not worried about that exactly. Okay, what we're worried about now is barotrauma. And so when you are taking a bag valve mask and you are squeezing it super forcefully and all of that oxygen or all of that air is going into the lungs, what can happen is, guess what? Think of anyone who's not your size. Their lungs aren't the same size as you. Okay. So there's no one size fits all, so to speak, with the depression of the back. So how do we gauge this? We gauge it by that chest rises. Oh, okay, we're good. We don't have to put any more in there. We don't have to depress that bag all the way every time. And I'm going to go ahead and tell you something that you're going to hear eventually, but let me go ahead and tell you now. If you take an infant and you depress that bag all the way, you are effectively going to kill that baby. That's all there is to it. Even though those BVMs are very, very small, you have to consider how much smaller their little bitty lungs are. So when you are shaking and you are having a really bad day because you're dealing with a baby, and you will be, remember when I tell you, only put in enough to see the chest rise. Because there's no one out there between you and that baby. It's just this. Okay, that's it. We're not doing a whole lot. We're not doing this with these babies. We're doing just enough. Okay. Chris has a great visual reference for lung sizes. Chris, I need you to put it in the chat box or text me.
Okay, I'll say it real quick. I like to talk. I hadn't talked a lot. So the way that I kind of do is a reference. So look at your Coke bottles. Think as a 1 liter bottle, your adult lung, and then step it down to like your 16, 20 ounces, your look at your age groups like juvenile to child, and then your infant is the little bitty, I call it like an 8-ounce Coke. Those little bitty bottles that you can unscrew and put the top back on. That's my visual response. That it's easy for me because I know I can look at it and be like, okay, I have to hold all the air that's in my mouth and I can fill the little bitty bottle up. Well, if I did that to a big 1 liter bottle, it's not going to work. So those are my visual references that I use for me, and I try to pass that on.
Thank you so much, Chris. I appreciate that. I'm totally stealing that for all of my classes from here on out. Okay, so number 10, and then we can get to go home now or turn off our computers, or some of us are already home. Okay, number 10, you and your partner are ventilating an apneic adult when you notice that his stomach is becoming distended. Uh-oh. You should A, suction his airway up to 15 seconds, B, reposition his head, C, increase the rate and volume of your ventilations, or D, decrease the ventilation rate, but use more volume. Number 10, you and your partner are ventilating an apneic adult when you notice that his stomach is becoming distended. You should A, suction his airway up to 15 seconds, B, reposition the head, C, increase the rate of volume of your ventilations, or decrease your ventilation rate, but use more volume. Okay. B, actually, okay. B, I have a couple D's. Okay. That's okay. All right. I'm seeing y'all. I see y'all. Y'all ready to find out? The answer is B. Gastric distension does occur when air enters the stomach. Why does the air enter the stomach? So how do we do that? How do we handle that situation to minimize that air amount that enters the stomach through ventilations? We should always reposition the patient's head. Okay, usually what that indicates is that the tongue has rested back inside of the mouth, and air's got to go somewhere. So it's going to go to the path of least resistance, and the trachea is more anterior than the esophagus. So air is going to go to the least, the one that's not as blocked as well, so to speak, okay? So suction is only indicated when there's something there to suction out, okay? There's nothing there yet. Keep going and there will be. The rate and the volume, by increasing, is not really going to do anything. You're just putting more air into the stomach, and the same thing, decrease your ventilatory rate, but use more volume. That doesn't make a whole lot of sense. You're still going to put more air in the stomach. So all of the above. But repositioning the head is the most correct answer. So I'm going to go ahead and stop recording. Thank y'all for watching again. It's been a minute. Stop that.